All right, everybody, welcome back. And we have one more video that we want to talk about in this mood disorder section. And it is about bipolar II disorder. So again, my hunch is coming into this class, you probably knew a little bit already about bipolar disorder. And my hunch is probably what you knew about was what we call bipolar I disorder. Bipolar I disorder, we just talked about in the previous video, is oftentimes called traditional bipolar disorder. Bipolar II disorder was created with the DSM-4 just a few years ago, and it is kind of another variation of bipolar disorder. And I don't want it to be confusing for you. Sometimes students get kind of confused with bipolar I and bipolar II. I'm just going to walk you through just the real basic differences of bipolar I versus bipolar II. Just real simply out of the gate, here's the thing. Bipolar II disorder is a less severe variation of bipolar I. Bipolar I disorder is more severe than bipolar II. Bipolar II disorder is less severe because it is characterized not by manic symptoms, but by hypomanic, HYPO manic, hypomanic symptoms. Now, all of you are familiar with the term hyperactivity, HYPER. The word hyperactive means overactive because the prefix hyper, HYPER, means over or excessive. Well, HYPO, hypo, like hypomanic, is the opposite. It means smaller or mini. And the easiest way to remember that bipolar II disorder is a less severe form of bipolar I is to remember that bipolar II disorder is characterized by hypomanic symptoms. Hypo meaning mini manic, M-I-N-I, mini manic. That's literally what hypomanic means. So bipolar II disorder is a mental health condition characterized by alternating patterns of depressive symptoms. Let's stop there for a second. So bipolar II disorder, if someone's diagnosed with bipolar II disorder, they still, like bipolar I, battle depression. They battle a combination of those 9 depressive symptoms that we talked about a couple of videos back earlier in your lecture notes. So depression is the common denominator between bipolar I and bipolar II. So depression, alternating periods of depression and hypomanic symptoms with bipolar II. Well, what is hypomanic? Hypomanic just means this. People experience some manic symptoms, but the symptoms don't last as long and they're not as intense. So with manic symptoms, the duration is at least about 7 days. Several of these symptoms that we talked about before, those 7 symptoms that we talked about, several of those symptoms at nearly every day for at least 7 days, and the symptoms are severe enough that they're disruptive to normal daily functioning. With hypomanic, because it's mini manic, here's what that means. Some clients, when they experience manic symptoms, they don't experience very many of them. They experience 2 or 3 or 4 of them. And the symptoms are not present like for 7 days. The symptoms are only present for 3 or 4 days. And they're not super, super strong to where they're super disruptive. So a person may not, so with bipolar II disorder, the person's manic symptoms or hypomanic symptoms may not be as disruptive as it is when someone has bipolar I with manic symptoms. So real simple, again, this was a diagnosis that was created several years ago because psychiatrists and researchers and counselors were kind of advocating that, hey, I have a lot of clients that I evaluate. They definitely have depression and they have some manic symptoms, but not many. But they're there and they're present and we have to treat them, but they're not super disruptive. And so it doesn't feel right calling that person, saying that person has manic depressive disorder or bipolar I disorder. So the APA in its wisdom created this diagnosis called bipolar II for those situations where a person has depression and they have milder forms of mania or manic mood that can include things like grandiosity, decreased need for sleep, flight of ideas, pressured speech, risky impulsive behavior. It can include any of that. But usually what we see with bipolar II disorder is there aren't as many of those manic symptoms and they aren't as present in the person's life for as long, just 3 or 4 days. So probably a year or two ago, I had a student who was doing her practicum. She was doing her practicum in a local counseling office here in the Montgomery County kind of area that was based in a church, and she was helping to lead some groups. And she came to me in class one morning. I don't even know what class it was. She had not had this class yet. And she said, Professor Killian, I was leading a group last night at this church where I'm doing my practicum. And there was a lady in the group who was talking about bipolar II disorder. And she said, people in the group were saying, what is that? And I was kind of wondering what that was. What is bipolar II disorder? And so I want to share with you just an example of how I responded to her, because we only had about 3 or 4 minutes to talk. And I just said this to her. I said, here's the thing. If that lady has been appropriately and accurately diagnosed, let's assume that. That's a big assumption these days, right? But let's assume that she's been accurately and thoroughly evaluated and she has been appropriately diagnosed. If that's the case, here's what we know about her. This lady battles depression. At some level, she has battles with depression. She also, too, has battles with some mild manic symptoms occasionally that we call hypomanic. And I said, those manic symptoms probably come and go pretty quickly, and they're probably not real disruptive. And probably what's more disruptive for her is her depression, probably. If, in fact, she has bipolar II disorder, then what she has is depression with some mild manic symptoms. We call them hypomanic. And the student said, that makes sense. I never heard of that. And I said, yeah, bipolar I disorder is more severe. Bipolar II is a little bit more manageable. And so I think about that every once in a while when I think about just ways in which we keep bipolar I and bipolar II disorder kind of straight, right? So bipolar II disorder, a less severe form of bipolar I disorder. The term hypomanic is easily and clearly associated with this disorder. Hypomanic mood goes with bipolar II. Manic mood goes with bipolar I. If you go and look on the very last page of your lecture notes for the bipolar disorders, I give you a really simple, really short little chart that gives you a little comparison of bipolar I versus bipolar II disorder. So let me also say this as we kind of wrap up this conversation. I've not done this yet, but let me just say this just real quickly. A couple of times whenever I teach this class, students will ask me about treatment and treatment options. I shared with you before when we talked about the medical model. You remember the medical model is symptoms lead to a diagnosis or leads to treatment. And I shared with you when we went over that conversation that this class is more interested in the first two. What are the symptoms and what is the diagnosis? But I want to talk about treatment for just a little bit. So number one, the bipolar disorders, bipolar I and bipolar II, and the major depressive disorders are highly treatable, which means we have treatments available. There's no reason for anyone to struggle with depression or bipolar disorder by themselves. There are ways in which we can and we do help those people. There are several ways. The two primary ways that we help people with depression and or bipolar disorder is through counseling and medicine. Now, does everybody need counseling? No. Does everybody need medicine? No. But usually, statistically, most people who battle severe depression or bipolar disorder, most of the people who have the best outcomes get both. They find them a good counselor or support group or a therapist, and they find them a good doctor who can prescribe medicine to help them deal with and kind of treat the brain chemical imbalances that are causing these two disorders. Again, does that mean that every single medicine works the same way on every single person? No. Does that mean that counseling is a cure-all? No. But we know that counseling and medicine are usually the two best ways that we can help people with both of these mental health conditions. Now, here's the problem with that. Number one, a lot of people have a negative stigma about both. There's a negative stigma in our world today about going and talking to someone about your problems, and there's also a negative stigma about taking medicine. So a lot of people do not get the help that they need because they will not go and get either one or both of those. The other problem is this: people don't always have access to that. Counseling costs money, and so does medicine. And so a lot of people do not get the help they need, unfortunately, because they don't have access to counseling and they don't have access to a doctor and therefore medicine. That's one of the reasons why people self-medicate, because usually marijuana and alcohol and those drugs are available and cheap. And so people can self-medicate their manic symptoms and self-medicate their depressive symptoms because alcohol and marijuana and sleep pills and anxiety medicines, those are oftentimes accessible and cheaper than, say, therapy or counseling or psychiatric medication. So unfortunately, it's one of the reasons why people oftentimes self-medicate their mood disorder symptoms, is because of the accessibility, and also too sometimes because of the negative stigma. Speaking of medicine, talk about medicine for just a second. There are a number of different types of medicines that doctors use to treat depression and bipolar disorder. Usually, with when someone's mood is is mainly depressed, they'll use what's called a mood lifter, or a traditional antidepressant, where the medicine is designed to alter the brain chemistry to where people feel better, their mood is higher. If someone has bipolar disorder where their mood is both high and low, we use what's called a mood stabilizer. And there are different drugs that fall into those different categories. When you go see a psychiatrist, they sort of listen for, well, is your mood high and low, or just high? It helps them to determine what kind of medication to use. Medication treats, it does not cure. It's an important thing. Medication treats, it does not cure. Medicine does not. So if I have bipolar 1 disorder and I take a medication, it does not cure my bipolar disorder. All it does is treat the symptoms of it. I have to learn how to manage the symptoms in addition to the medicine. So there's always the self-management. There's always the personal responsibility part of, number one, taking my medicine, but also two, learning to manage my symptoms myself in addition to my medicine. So medicines treat, they don't cure. Second thing is this: medicines don't always work equally in every single person. And so again, there's all kinds of variability with medicines. One medication, someone may take it and it may affect them in a positive way, works immediately the first time. Other times, people take a medicine for 3, 4 months, doesn't have any effect on them at all. They got to change medicines. Everyone's kind of different. And so there's a lot of variability with medicines. And so medication is an important thing for us to think about. The good news, I believe personally that it's good news. I think it's good news that we have today treatment options available through medicines and medication and doctors for many of the mental health conditions that we talk about in this class. And so I'm not a believer that everybody has to be on medication, but we do have medicines available. And many people who struggle with bipolar 1 and 2 and major depressive disorder, many of them are maintained and manage their symptoms through medicine. There's no shame in that. And that's an important piece. And then there's the issue of counseling. Just like medicine, counseling is not a cure-all. Counseling does not cure, it treats. It does not fix people's problems. It helps people learn how they can better manage themselves, and hopefully better manage their situations and find different options and solutions for their problems. So there's no cure-all available, in counseling. Not every single counseling approach works the same way, the best way with every single person. And not every single counselor works the same way with every single person. There's a number of different counseling approaches that we use. Most often, what we see with the mood disorders, a lot of cognitive behavioral approaches. Some of you have been with me in the behavior modification class, or the counseling theories class, where we talk about CBT. And cognitive behavioral approaches, a very broad counseling school of counseling, are usually the most commonly used and resourced approaches when it comes to working with mood disorders. The cognitive behavioral approaches combine both working on people's cognition and then their behavior. And so it's real good for mental health kinds of conditions like depression and bipolar disorder and anxiety. So a lot of CBT, or cognitive behavioral approaches, are oftentimes used in mental health counseling as well too. So I wanted to give you a little bit of just additional information at the end of this video, as we talk about treatment a little bit, because I know many of you are interested in not just the disorders, but how do we help people with these disorders. And so I want to give you a little bit of information on treatment as well too. So in this module, we've talked about major depressive disorder, primarily bipolar 1 and bipolar 2 disorder. Go and look at the PowerPoint presentation, go and look at the DSM-5, go and find the lecture notes and the handouts and the case studies as you get ready to do your homework and take the quiz for this module. And we'll come back and talk about anxiety-related disorders next time. I'll see you then.